Great. Okay, good afternoon. And I'm going to talk about some of the numbers, mostly about how things are transforming, what's happening. As I've been talking about before, what do we need to focus on at this time as we're in this process? And so with that in mind, I'm going to ask Dr. Yaffe to give you an update on the numbers, because that puts some of the context of some other comments I'd like to make in regards to where we're at today and what we need to do over the next number of days.
Okay, thank you. So I'll just give you a few highlights. At this point, we're doing about 3,000 lab tests each day, and we anticipate by the end of this week, early next week, that we will be up to 5,000 a day and hoping for even more capacity to come. Of course, we are dependent on the supply of the lab reagents. Most of the labs are now running multiple shifts, 24 hours a day, 7 days a week. And before I get into the Ontario numbers, I understand from the federal government there are now 12 cases, positive cases at Trenton. We continue to monitor that situation. And the U.S. border will formally close as of midnight tonight. So in terms of the Ontario data, and this is data from the labs as of 4 p.m. yesterday. So, of course, it has changed since then. We have a total of 301 confirmed positives, plus the 5 that have resolved and the 2 deceased, which gives you a total of 308. The number has gone up 50 since yesterday. We still have 5,485 that are, we call under investigation, so they are still to be tested or under the process of being tested, and a total of 13,718 that have tested negative. So at this point, almost 20,000 people have been tested in Ontario. In terms of the percentages, it's very similar to yesterday in terms of the majority were travel related, with the top exposure site, so to speak, was the United States, then Europe, and then other countries, and a smaller percentage were contacts of cases. There are about 20 to 25% of cases that are still under investigation, and a small percentage of those are unknown source. Thank you.
Okay. So in light of that, and with the issues we're dealing with there, is we have the situation in the United States. We didn't do the global numbers. We're not going to cover all those. Europe has surpassed China in many ways. The United States, remember, we were talking about 6, then went 11. Now it's 14,000 cases. So it's rapidly escalating in that situation there, with up over 200 deaths already. And so that's concerning to us, and that's with the issue of the border closing this weekend, and to know all but essential, and there's various things that are going to be identified as what that means and doesn't mean. That's between the federal authorities to settle in that light, and they're trying to understand what those unique aspects are, and we'll be guided by those directions when it comes. In that time, the other aspect is that we're getting some clusters of cases in long-term care facilities, and those are requiring the health departments to do the investigation of the cluster. We continue to identify a lot of travel. We continue to identify a number that are out there with after the preliminary investigation and sometimes more investigation, there doesn't seem to be a travel history or a case contact history in there. And so the common term that people are using is one called community transmission, and that's can happen. There's a community transmission like in the long-term care home. There can be one in a part of a neighborhood, and there can be one in a community, but not necessarily one in the next community. And so in that sense, there's different people use different words and terms for that. The key thing is here, even with these cases, what we've been trying to do is we do our containment, as we talked about before, and now we've added in the social distancing. And we brought in emergency measures to really take further steps to enhance and carry that function out. What I said yesterday, and is especially important, is that this coming weekend and early into next week is a very critical time. And as I said, with the number of people returning, starting last weekend and into the early part of this week that we're here, we're now coming into day 5, 7, and 8 of that post-return time, as the number of returnees have either come back and are here. And some are potentially incubating because they came from various parts of the U.S. where there has been more and more cases identified, and that's being identified much more effectively as the testing is really picking up in the United States. So the maximum time of case counts, and we're seeing before, even with our Trenton group, is around that median time of 7 to 8 days since they were last exposed. That means it's this weekend, early next week. And I can't emphasize strong enough, as I said before, this is the time to really, and I really appreciate what I've seen people doing. People are taking it seriously, and they need to take it seriously. Because in essence, even with these cases that are out in the community that have no travel history and no contact history, if they're continuing to honor and they're doing what they're doing and staying at home, social distancing, they have posed no risk to the community. They pose no risk to other people. How they got it, maybe someone didn't, and they're unaware of that happened. And that's when you need everybody doing it. And that means in the settings you're doing it in, and focus on that. And I see people doing it. There are some people who are choosing to be casual on it. And I really strongly emphasize that's not to be done over the next 5 or 6 days, because this is the critical time period. In another week or so, it'll be 14 days out of all the people returning. And we can look at that again. If we don't do it stringently, and we continue to see extensive amounts of so-called community or a wider transmission because people are not adhering to that, then it'll go longer again, because we have not maintained that type of discipline in that time. And so that has all sorts of impacts of how long we're going to keep doing some things. And can we be effective and lock down really hard now for the next 5 or 7 days? As I said before, this is within our control to do that. And we're not like some countries where we send armed forces out and that kind of stuff there, because I feel that Ontarians, for the most part, 90-something% know about it, want to do it, are doing it. And I think you hear them talking about it with their families. It's not easy. It has its challenges. But I think keep rising to the occasion, and we can handle this in the days coming up. And so that's my message, key one I want to focus on. And I feel sometimes when people don't follow that, it's really quite disappointing when some other vulnerable people are put and exposed and become ill because of carelessness about honoring that type of social distancing and managing the personal hygiene in all the ways we've been saying again and again and again. So it's not a complicated skill task. It's very straightforward, but it takes assertive discipline and consistency to manage yourself in that way. Not going on for months. We're talking about really now for the next 5 to 7 days. Hold in there tight for that time. So with that, I'm going to take questions, and I'm going to take it's on the phone first.
We're going to start with questions on the phone. One question, one follow-up.
Your first question comes from Travis Daharaj, Global News. Please go ahead.
Soon, doctors. The province is not testing everyone that needs to be tested, and in fact, you're turning away people with symptoms in many cases. So my question is, what is the point of tracking data if the data is completely inaccurate?
So what we're finding out is that there are various different ones because some of the different centers have different leads on that, and they're making some decisions on prioritizing because they're concerned about the availability of the tests. A few days ago we had what seemed like only a few days of swabs left. We just got a large shipment from the federal government. They acquired a very large volume of these kits. So that pressure has ended. We're looking at the issue of the other parts of the testing system to ensure that we can, as Dr. Yaffe's already alluded to not only meet the needs and expand up to 5,000 tests a day. We haven't had that capacity. There's been some backlog, and some leads and some clinicians feel that they want to keep something intact so they can make sure that ones that are very high priority in their mind still get done. And these ones that especially are more clinically complicated, admissions, inpatients, etc. So I believe some are making decisions that they feel in their judgment is the right way to settle that. We're trying to put out some clear directions and guidelines. And as you're alluding to, we would like to be able to say that we can test everyone if we could, and we want to make sure we have the infrastructure in that to deliver it. But also, as you've seen, we've had some delay of 4 or 5 days with some backlog. We want to really ramp that up to get back to where we were before, of saying it's between 6 to 12 hours is where we like to be, because as some centers would say, there's some patients, if we see them, we do really need to have that result back really quickly, and therefore they're making, I guess, their own version of deciding on priority basis on that. So I can't speak for all of them at this time, and it's part of what they think is their best way to protect the system as they see it. But we're hoping that by ramping up our lab testing very much expeditiously, that we might alleviate that decision making and go to wider testing that one there. So I understand your point, and we're trying to bring in a system that would allow a consistent, more open, wide testing that keeps the data and the performance up of what's going on throughout the province.
Okay, follow-up question?
And just as a follow-up, how are you supposed to advise the government on what steps that they should take to protect the public if you have inaccurate data, and how do you do contact tracing if you're turning people away?
Well, the key thing, as I said, my main point is that with the very strong messaging I was giving, is that if someone is positive, someone has a travel history, okay, let's say someone has a travel history and they're within that 14-day window, they have a contact with a case in that 14-day window, they're supposed to stay in home situation, not have social contact or distancing in that line, or perform high hygiene. If they get a positive test, they're supposed to do that for 14 days, by the way, from the time they became asymptomatic. If they get symptomatic, then they're supposed to stay at home and do the same thing again. If they get a test result and it's positive, they're supposed to do the same thing again. So it doesn't change their responsibility and response. What's most important, if someone is in that situation, this is where I think the clinician was making a decision, if the person deteriorates and becomes more ill, and then you have to follow them that. If you're doing the case contact, then one assumes that when you interview the person, they said, well, I didn't quite stay home, I went out and did this and this and this and this. Then we have to do contact management because they didn't stay in their situation. That's where the workload commands. If everyone did what they're supposed to do, there's no contact information because there are no contacts.
Okay, next question.
Your next question comes from Siobhan Morris with News Talk 1010. Please go ahead.
Dr. Williams, in a similar vein, I wanted to ask about when we do move to broader testing. Does it happen after we move to 5,000 a day? And once we're out of this period where all the people are returning from away travel and the border shut down, is that when we would move to if you have symptoms but don't have a travel history?
Okay, good point. And right now, because we have the 5,000, and we may even try and push it higher in that light there, is that, and we're trying to be informed by some revolving science and how we're going to do it. So I think you're correct. After we're through that 14-day period of when the border closed, people didn't go on March break, schools closed, all those kind of things there. So the travel history, as you're alluding to, will become less and less of an issue all the time, and maybe down to zero. Then you may say, well, then who's going to be tested? We'd say, well, there's no travel history, no contact history, and we won't do testing. Our clinicians in that won't agree to that. So I think if we have the latitude, we can look at that question and saying, are there other ones, like we're doing our syndromic surveillance? Will we expand it even further? Will we do some sampling in other ways? All these things are possible in that. As Dr. Yaffe has said many times, our 90-odd% of our cases have been travel and case contact thus far. As you're saying, as that drops off with border closing and all the measures we put in there, that kind of thing will drop down. We may have more latitude, one, first of all, to decrease the time for lab results to get back, to make sure those that are most critical and priority things get done, and then to look at further surveillance. Outside that, we might want to look forward to say, is there any other ones that we're missing? and that's our enhanced surveillance and our sentinel surveillance. So it's a good question. It's one I'd like to be able to deal with in 14 days, that we have no one has traveled, no one has been exposed. I think there's still be people exposed to cases because we still have cases occurring. But if that out of the way, do we have some more latitude? So I'd like to be able to have that challenge.
If I could just, add to that. I mean, we're not saying right now, do not test anybody if they didn't travel. You know, it's a clinician's decision, but I mean, there are certain groups that are particularly important, you know, if they're symptomatic, like healthcare workers, people who, like as Dr. Williams said, people who are being admitted to hospital, people in long-term care facilities or workers. So, I mean, there are certain groups that are particularly critical to be tested. But we are not unique in having this situation. This is a situation that's happening across Canada. And in fact, there's a meeting today, which we're not at because we're here, but we have staff on with the other federal, provincial, territorial officials looking at this very question. With the lab testing capacity that exists, who should be prioritized for testing?
Follow-up?
I just wanted to see if you appreciate that that can be a bit confusing for people, that, you know, it depends on where you live about whether or not you might get tested, even though you're saying that you're sick.
And I think what we've been putting out with the self-assessment tool, and with the work then moving on to, and a couple things we're trying to work on there is, one, we've greatly increased the capacity of lines and staffing at telehealth, and they're getting up to about 20,000 calls in a day. So people are doing the right thing, asking and getting information. We've also, with a self-assessment tool, because if you've had a travel history, let's say, or contact with a case, you have been asymptomatic, then you start getting a cough and achy and a bit unwell, the chances are you may be actually a case. But then you're supposed to stay in isolation and monitoring for a further 14 days. And if you get better, then you're no longer a case. You're basically back to being Jane and Joe citizen in that regard. If you do go and get a test in there, then you'd have to do the same thing anyways. So some are saying from priority basis, what should you do in that regard? Does it change anything? I think in response to that, as Dr. Yaffe said, there's a number across the country are dealing with the same challenge as the amount of testing has gone up. And people have to say there are still priority ones that need to be tested. There's still physicians who will test people without a travel history or without an identified case one because they're concerned the person's ill and it seems like it's a respiratory one. They want to rule out that it's not COVID-19. And they can do that all along. We have been doing that and will continue to do that. So I think in that sense, the other one we've added in is with the new K codes, so physicians can bill for telephone consultation. And I've heard anecdotal, some reports of people who have used that back to their primary care physician, and they have dedicated, because the doctors are not seeing a lot of people in their offices, they dedicate someone, either themselves or in their group, and they got all the information they wanted. They had a long talk and discussion, and they had their questions answered. So we're really trying to push people back to say, now we have alleviated that, and working with the OMA, can you now, instead of going to telehealth, do you want to call first your doctor's office? And they will usually tell you, if you wait, give us your phone number, and someone will be calling you shortly, and we'll address your issues and concerns. So that's something we're really trying to build on, because everybody has a trust in their primary care provider, and they would rather talk to them if they had a preference. And I'm really pleased if that's going to really escalate now in the next while, because we're bringing our primary care community right back into the center of it, which is what we've always wanted to do. And so try that out. Call your family doctor and see what information they have to give you if you have questions and concerns as well. So it's another tool in the box. We're dealing with this onslaught of concern and with real questions that people are looking for.
Or now, let's just also do one question, one follow-up for now.
So, Doctor, just wondering if you could explain, there seems to be some sort of difference between your directives and also the Ministry of Health. We know Christine Elliott did say that healthcare workers, if they have traveled abroad, they should self-isolate, they should stay at home for 14 days. But we're hearing from hospitals, your directive is if people have traveled outside, they're healthcare workers, they should still go to the hospital if they're asymptomatic. And that was, as of yesterday, there was a directive from yourself. So what do you say to healthcare workers who are not feeling safe on the front lines, to say they don't feel like they're being protected?
In contrary to that, my memo yesterday clearly said, if you've been away 14 days, you've been out in 14, you isolate and stay off the job. It does say, if there are in that healthcare setting certain critical positions that all parties would agree ahead of time, and there's a real need for, that someone could come back before that 14 days, if everybody agrees on it, and they're asymptomatic, and they wear proper PPE, and are monitored. So that's not inconsistent with what the minister said. So we've never put out that everybody has to. Now, there are some institutions before, that's why we put the memo out from my office, because they were doing they were taking it individually and saying, we're expecting our staff to come to work regardless. And so that was leaving the workforce a bit confused, because one would say yes, one would say no. So the minister and I both wanted to put out a consistent message saying, this is the way forward on this one here, in that, because we've had some go back before, I mean, they're asymptomatic, they went back to work and became symptomatic on the job, and then that means then we not only have that person off, we have a bunch of others, because now they have to isolate in that regard. So it does compromise our healthcare system. And at this stage, because the healthcare system still has flexibility in it, and we can allow those people to complete their 14 days, so we don't have the patient load pressure to bring them back and put the rest of the system at risk at this time. But if they agree with the labor management group of certain key positions, if they need to do so, they would do so. That's mutually agreed upon, and with the employee as well.
Just to get it clear, so if they're deemed critical and they're asymptomatic and they're monitoring themselves twice a day and they're wearing the mask, they can go to work if they have traveled outside the country, though, if they're deemed critical and this is agreed upon between the labor union and the healthcare system.
Correct. They do that ahead of time, because there may be in some smaller places only so many staff are in, like, say, a coronary care unit, and you need a very specific skill base that you just can't bring someone in, and it may be unique, and that's why, what are those critical positions? And I think that's why you have the management sit down with the labor group and saying, both sides, this is critical, that's true, and it seems okay at the moment, but if there's a shortage, which could happen, because people get sick from other things, and they're not there, then we need someone to do the job. And do we understand that? Hoping that we don't have to, because they let the person finish their 14 days if they did travel, which, as you can imagine now with our timelines, we're already 6, 7, 8, 9 days into it, so it's not too far off. So it should be a moot point after a while.
Okay, and we're going to move on.
So, from my understanding what you're saying, people are coming back from March break. So our future is basically in the hands of these people who are coming back from travel, and hopefully they abide by the rules, stay home for 14 days, and not try to organize a get-together for a birthday or anything like that. It's kind of up to them.
That's a very key group that they really have to hold tight on that, because they don't know if they were exposed or not. And so I think they're wondering too, because they assumed I thought I was going to, when I left, I went to some place I thought was fine very much, and now I hear there's cases there and people coming back and getting sick. So they're wondering in their own mind, will I get sick? And then how do I get assessed? So there's that aspect too, but because others may have contact around that while that person's there, if you're not being stringent with everybody else doing it, you may start having even community-wide, not just community transmission, community-wide transmission, which is a different concept, where it goes through, like we were concerned with the school closure for the children, who could obtain it and may have only very mild symptoms and be ignored, and then you get it spread all through the whole school system and through the daycare system. And so we've taken those steps to limit that. So that's to avoid that possibility of a miscue. And because even now we hear some cases where people did go back to work while in the 14-day period, they did go out and do something in that 14-day period, whether they were aware of it or not aware of it. It's unfortunate in that. So I think you're correct. It's that one group, that large group coming back, 200,000 to 300,000, maybe up to 500,000, because there's quite a few, that really have to adhere to that protocol to wait for their 14 days to know that they're in the clear.
I mean, that's how many people are coming back?
Those are the people mainly coming back, because they have to do that.
500,000 people approximately?
Well, we hear the numbers. I'm trying to get some numbers from the Canadian Border Securities to say, we know sort of flights, even those are dropping, right? Because none of them are stopping. And then at the land crossings, I'm asking, say, can you give me some numbers? Because I want to see how that number should start to drop down over the next number of days, especially with the border closure.
Okay, we have to move back to the phone line. First question.
Your next question on the phone comes from Maura Warburton with Reuters. Please go ahead.
Hi. So I'm just wondering if you can comment on the cases that are cropping up in Ontario's prisons. What action do you think needs to be taken, and is it being taken? Is the correct action to prevent that and to protect the prisoners and the people working in it being taken?
Okay. Yes, we understand. They're working on one area where there seem to be cases that there are one or so in an institution, and this is very concerning. And already before, in that part of the ministry, they have been setting some things in place to try and prevent, again, try and do the social distancing, if you may, in those institutions. So if you have a case, they have to move quickly to find out if there are some in that social distance area and see if there's any signs or symptoms and move on the management of that. So we're going to be monitoring how that works with the staffing at those jails and institutions with public health to be satisfied that much like you would do at a long-term care institution, it can be cordoned off and handled quickly and monitoring so that other ones are not exposed, especially because even in there you have several at-risk populations. You have some people with comorbidity and some are over the age of 50 and 60, so they're at risk, and there's other steps they can do in that. So this first one we're hearing about will be a test to see how well those things are put in place and how well they're going to manage that in partnership with the local public health.
Okay, next follow-up question.
Yeah, I have a quick follow-up question. You mentioned clusters of cases in long-term care homes. I'm just wondering if you can tell me how many clusters and how many long-term care homes are seeing cases.
Well, I'll speak to that. We're aware of 2 long-term care homes that have clusters of cases. And one is in Durham and the other is in Halliburton Kawartha Pine Ridge Health Unit. And they're both being intensively investigated by the local health unit in collaboration with the nursing home and the Ministry of Health and the Ministry of Long-Term Care. I just want to say that in outbreaks in institutions like long-term care homes, like prisons and so on, these are things that public health has been dealing with for other infections for many years. It's not unusual. I mean, these are circumstances where you bring people together, and not quite as difficult as a cruise, obviously, but this is basic public health work. Case and contact management, infection prevention and control, working with the staff to make sure that they're doing whatever needs to be done, that cases are identified as quickly as possible and isolated, however they can do it.
Okay, next question.
Okay, and sorry, how many cases at the long-term care home?
Well, I don't think I have the most up-to-date data. These things are changing. As far as I knew from Durham, it was 4 cases, but that could very well be out of date at this point. Mm-hmm. The other one had 3 positive specimens, lab tests, but as we know, lab tests don't represent all of them. There are a number of other residents and some staff who have symptoms, and the numbers are changing.
Okay.
Next question.
Okay. Thank you.
Your next question comes from Jessica Smith with Queen's Park Briefing. Please go ahead.
Thank you. I was wondering if you could explain the extent of the Sentinel surveillance right now, and if it has still found nothing, or if it has found either in long-term care or in hospitals.
The Sentinel surveillance, which you're asking about there, is that we've done 1,987. That includes both EDs and inpatients, as well as outbreaks in long-term care facilities. And so far, of those ones, 1,820 have been, 21 to be exact, have been negative. There's still 166 pending. So there's been no positives thus far in that. So if in this case here, if we're finding positives, it tends to be already identified in an outbreak modality specific to COVID-19 in the long-term care visits.
And then how many institutions, hospitals, and long-term care homes around the province is that happening in?
Oh, I mean, these are all in the long-term care. These are happening. Our monitoring of this situation is throughout the year with the health units involved with that. And if you ask me to quote off the top of my head how many there are, I will get the number wrong. But as Dr. Yaffe has alluded to, that we do outbreaks all year long with quite a number, hundreds of small outbreaks with influenza and other respiratory viruses that have to be dealt with. And they have a very strong partnership between public health and the staff at the long-term care facilities in that, and to make sure that the outbreak is handled quickly and effectively. And they've been getting very good at it, or very efficient and very rapid response over the last number of years.
Next question.
Sorry, how many hospitals?
In hospitals?
Yeah.
The hospitals were getting samples from patients who are admitted to the emergency department with respiratory symptoms, could be influenza-like, and they didn't do testing in that case particularly, or they might have been admitted, they may be in ICU, on ventilators for other things with respiratory, and they do samples, and then so that public health lab will then take those samples submitted for other causes and reasons and do parallel testing with the COVID-19 to see if maybe it could be and we're just missing it. And so far, as I said, they have been negative, so that's what they're doing in the hospitals.
Okay, we have to move on. Next question.
Next question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi. The City of Toronto has asked all non-essential businesses to close. Are you considering that measure province-wide at this time?
We've had a lot of discussions, even at the federal level, trying to look at what's essential, what's non-essential, and it's not an easy one because there are a lot of things in the supply chain that are necessary that some person may feel is not essential for me, but another person said, excuse me, but for me it is very essential. So we want to make sure I understand that. My main thing in there is that whatever these ones are doing, are they maintaining the distancing? So I think some of the examples given by, I think, Dr. Davila as an example of what she was alluding to in there and asking people to adhere to that, I think I would guess that I think it was a nail salon and hair salon. I don't know how you can do that, be standing 6 feet away from the person. I just can't see how that's going to work. And I think a lot of ones that did that kind of stuff have stopped doing it because how can you maintain the distancing in that kind of setting? So I see a lot of them have closed anyway. So, but maybe there are some that are not complying, and some people feel that I guess those services they think are essential, which I don't understand totally in that. So that if you can deliver a service and still maintain distance at all time, there are ways to do it. Like some people are asking for like takeout restaurants. People with other services, they have it picked up at the door. They pay online ahead of time. Something they deliver and drop it off at the front of the door because they've already paid for it. I think the retailers are finding very creative ways of doing that, and some people, they feel it's essential, they want to have that, but there's a way to do it safely without violating our key things. I said the issue is the distancing. This coming in 5-7 days is going to be very critical.
Follow up?
Just wondering what your advice is on playgrounds specifically. I've seen a lot of discussions among parents about what the best practices for that are and what the transmission possibility is, like how long the virus could live on those surfaces. And some municipalities have been posting signs warning people not to use playgrounds and others haven't. What do you think of that? Should there be something uniform across the province?
It's one that's come up again and again. You've heard many experts been asked about how long it stays on surfaces, and they all give the same answer as I would. Generally, if conditions are not too harsh, as in -10 or 15 or something like that, they can be like 1 to 2 hours sometimes. It depends on a lot of circumstances, the humidity, the warmth, the temperature, the surface, and what's involved in some say phlegm or sputum and stuff like that. I don't want to get too gross, but it can stay a bit longer. So it's mostly in that range. I think with playground equipment, I I think even outside of COVID, if your children are doing that, you have to understand there's a lot of stuff on there, and usually you have your child, you have some wipes or something to wipe their hands off after they play on it, and especially the younger ones quickly put their hands in their mouth very fast and stuff like that. So you may have to decide, it depends on your child's behavior, how much they will be attentive to that or not, whether you want to let them play on the equipment in there, because you have to do that risk assessment, and you may say it's not worth it at this time, or there's this type of equipment is less more problem than that equipment. If it's just like a swing and I clean it off before my child gets on and I push my child in the swing, then I can take control of the situation. So across the board, I would say, of course, if you don't play on them, I guess you remove that risk, but then you're dealing with children at home for long periods of time and they want to do things, and older kids will try to do proper hygiene, hand washing, or have wipes with them, clean their hands afterwards. That's the main thing of concern. And even little ones put their mouth on stuff and lick some of the metal things, which is a bit gross, but that's what little kids do, and you got to watch that and hope your child, if you're not able to do it, then you try and limit it that way.
Okay, we're moving back to the floor. Mike?
I just wanted to follow up on Allison's first question there about businesses that are remaining open. The Premier said in his news conference that he will not hesitate to issue more closure orders if you give him that advice. Why are you not giving that advice for more closure orders?
Yeah, I think one is I have to be advised by my different ones out in the field if they feel that people generally are not being observant. And regardless of the alerts out there, they're not doing social distancing, there's large gatherings, over 50 people and stuff like that. And so if people are not complying, I would recommend to the Minister and the Premier that they need to take more strident steps, because they have the ability to make those orders. And local medical officers can write orders against those facilities if they have to. So they have powers. I have some powers. The Cabinet has more powers now to do that. So I think it would be more on the fact that if we thought there was a large amount of violation or people doing that. And I think probably there's a few that may not be adhering, and they may have to be dealt with. You try to come out and warn them, saying, you should not be doing this. What are you doing? And as always in public health, you start with warning, education. Did you not understand what the rules are? And will you not do that again? And someone says, well, they're back at it again. You go back and say, do that again, we're going to close you. And you do it again, we're going to fine you. And do that kind of stuff. There's various things we can do. It's difficult to say if there's just one or two and the whole sector is branded with it. And that's unfortunate.
Just to follow up, I've just gotten off the phone with 4 senior folks within the hospital sector. Every single one of them, without me prompting them, said, when I said, what are you concerned about? They said that the social distancing, that people are not taking social distancing seriously enough. But they said, why is there not a more consistent message coming from you that says social distancing means stay away from everybody? Why isn't your message stronger?
You missed my strong message at the start of the press conference. And that was my strong message. And it still is my strong message. And it really depends, as I said before, even with WHO and others, you can put in those social distancing programs, the public health measures. It's really contingent very much on the public's participation, that they understand it and see it and do it consistently. We can't watch everybody every moment, but we do ask them to say, you need to watch yourself every moment, especially in the next 7 to 9 days.
Okay, thanks everyone.
Thanks, doctors.
Thank you.
Why didn't you get here?